Hi, and welcome back to the last section, part 6 of motivational interviewing as part of SECSAT-APRN's overarching curriculum. Again, my name is Annie Beers, one of the co-authors of this module, along with Mr. Alan Lime and Dr. Sylvia Schellenberger. So we ended section 5 by talking a little bit about change talk, and we're going to begin this last section by focusing in on it a little bit more and just defining what is it really. It's when a patient expresses motivation to change. So you may hear a patient say, I wish I could stop drinking so much because I don't want to be that example to my children. So what is the change talk then that you can pick out of that statement? She's tired of being the example that she is to her children. That's her motivator to change. That's what she's going to use sort of as her fuel to think about making changes. It's not that she feels like she can't stop. That would be the sustain talk. Change talk, sustain talk, they're all a part of what's completely normal for all of us, which is ambivalence, just sort of being stuck in the middle. So we want to keep in mind that when a patient's talking to us, they're going to use a little bit of both. They're going to give us some reasons why they could or why they should change, along with why the behavior is stuck at status quo. It's important for us to just be aware of that, to acknowledge that, and then from there to know that we're all ambivalent, or we at least all have been about some things in our lives. I was thinking perhaps maybe you were ambivalent even about starting your advanced practice nursing degree, but now you resolved it, you chose to be in it, and it's a good thing because now you're getting this motivational interviewing module, right? So, as we think about change talk and presenting it back to a patient, keeping in mind the summaries that we talked about earlier in our ORs, when we offer summaries, effective ones, in a motivational interviewing conversation, we offer back to the patient the change talk that they've expressed. And we liken this to the analogy of sort of the conversation, as you move through the conversation with your patient, picture that you're out in the middle of a field, and as they talk, some things that they say fall in the field and are actually weeds or something undesirable, but then as other things that they say actually bring up flowers on this field of conversation. Those flowers are the things that you're going to go and selectively gather to offer back to them. These are the reasons that you've said it's important to you, that you feel like you should change, that you feel like you might possibly could change. So in our summaries, to really just glean the change talk from the sustain talk and leave it out, and imagine it's like a bouquet now that you've given to the patient. So we've worked through the spirit of MI as just our foundation. Again, that it's about an underlying perspective of accepting the patient, meeting them right where they are. Went through 4 principles of MI, resisting that righting reflex, being the final one that we talked about, the resisting the urge to come in and fix either the patient or the patient's circumstances. Talked about the steps of MI, and also the ORs, sort of the skills that we use to move through the steps. And in talking about that in summaries, just differentiated between what change talk is and what sustain talk is. So now that I've given you a nice summary of this module from start to finish, let's now move into, so you've done that and a patient is actually expressing some desire, some readiness to make a change plan. So now what? How do you do that with the patient and sort of stay within the vein of MI? So you definitely want to invite active participation. And you can certainly do this, again, by asking permission. It's fine to have asked permission at the beginning to talk about it, but again, to just acknowledge the patient's autonomy, the patient's own participation, and say, is it okay with you if we take just a minute to think about some practical steps that you might be able to reach, and have the patient voice their readiness to actively participate with you in making a plan. And from there, after the patient's agreed, then it's the patient who determines what the goals and the priorities of those goals should be. The clinician's goal then is to just be with the patient as they form those, reflect back what you're hearing to sort of narrow it down if that's needed, help the patient weigh the options with a decisional balance perhaps, some nice summaries, and then together you sort of work out the details of what the plan should be. So in doing this, it's important to remember different strategies work for different people. So again, there's no right way. We all come to the table with different histories, different things that have made us apprehensive or things that have made us strong. And so to remember that while, for example, Celebrate Recovery or AA or some 12-step program has worked well for several people that you've encountered, it would be ill-advised for us to assume then that must work for everyone and just suggest it to our patients. But again, just evoke and elicit from our patients what they think may be a good idea, holding the space open for them that not one thing is going to work for everybody. As you work through making the change plan, it's also important to consider how accomplishments have been achieved in the past on the patient's end. So what is some goal for change that they've made in the past that they've been able to reach? And as a patient talks to you about this, they start remembering ways that they've been strong or ways that they've been committed to change in the past. And recognize that it may take several tries to find the right strategy, and that's just part of the process. If anything, perhaps you being willing to accept the fact that a strategy didn't work and it may be time to look for a new one, again, accepts the patient where they are and where they're coming from to you. And again, lets them just know that through the process of creating a change plan, you are an ally and they can trust you. As you move through, it's great to troubleshoot with open-ended questions. So we've given you some really good examples of these that you may just want to keep in your back pocket until they're just first nature. If you want to take that route, what are some of the things that you want to be prepared for then? So this gets the patient thinking about what some obstacles may be. And follow that up with, well, how might you respond to that hurdle or that obstacle coming across your path? So continue evoking from that patient and not necessarily prescribing what they should expect or what they should do. And after you've done all that, you want to again offer a really nice summary, a nice bouquet of flowers, and close on good terms with them. Express the fact that you feel great about patient strengths and the work that they've done in talking with you. Highlight the plan that you two have made together. And then definitely arrange for a follow-up. So this lets the patient know that you're going to be curious about how the plan is working, that you're going to want to offer continued support and continued resources if the plan that you've come up with today actually doesn't end up working the way the patient had hoped. So depending on your instructor and your learning setting, this may be something that you do now with perhaps an unassuming friend or family member. Perhaps you do this with another student online or even in class. On this end, it's impossible for me to know how you might go through this learning exercise, but we've provided it here because it is really crucial and important as you now have learned about MI that you practice it. And it's in the practice that a lot of what I've discussed will actually become organic to you and in a way that you can understand. Because it's one thing to just hear me say this works or this is helpful or patients respond, and it's another thing entirely to keep trying it yourself and seeing for yourself. And again, all of our patients are different. We're all different. And so our personalities are going to inform exactly how we utilize the skills of MI. And that's great. That's fine. That's encouraged. But you won't know unless you try. So again, I highly encourage you to try. And here is just one way that you may do it. You may pair up with somebody. One person will be the speaker, and we'll just talk about something that they've been thinking about changing but haven't yet made any changes to. And so the other role player will play the role of the APRN. And so here are the tasks for you. To listen carefully with the goal of understanding the dilemma and give no advice throughout. 3 possible questions to ask and then reflect back the answers to are, why would you want to make this change? How might you go about it in order to succeed? What are some reasons, 3 reasons perhaps, that you may do this? And then give a short summary or reflection of what the speaker has said are his or her motivators to change. After the reflection, just ask, so what do you think you'll do? And just hear from the patient where they're at. After you've tried this, take about 5 to 7 minutes, and then consider for the speaker, what was your experience of talking about the change goal? Where did you feel really heard? Where did you feel accepted? Where did you feel the APRN was actually being the most helpful even or constructive? And for the APRN, what was your experience? What were the hard parts? What didn't feel natural? What was kind of weird? And on the other hand, what were the easy parts, even if that was surprising and you didn't think it would be as easy as it was? And also just what you might try again. What you feel like not only you did well, but the patient or the speaker responded to well, that you might try again. On the other hand, it could be something that you realize you're really rusty at and you need more practice. Again, I encourage you to practice. I had to do it. Anybody who wants to continue to use motivational interviewing and use it well will attempt to use it and maybe it not be so well for a while before you get comfortable. So I encourage you to do that, knowing, of course, that it won't be instantaneous. So we've come to the end of our final section, and I just would like to say thanks for sticking with me through this. I really hope that it has been informative, it's been helpful, that if you've been able to role play by the time that you're seeing this slide, that it was a really great experience and leaves you just wanting to do more role play. So in good MI form, I'll end this by summarizing just the motivation for change. So it arises out of exploring, amplifying, and then resolving discrepancies. Ambivalence is normal. We all have it. We all have felt stuck about a decision at one point in time or another. Some of us are currently stuck in some decisions. And empathy is the basis for compassionate conversation. And again, empathy is what sort of takes us back to that spirit of MI, that it's not something that we do to or on someone, but something that we do for or with them in an attempt to understand their world and an attempt then to understand how their world might be changed for the better. So congratulations on making it to the end. I would highly recommend, if you have additional questions or want to do some further study on motivational interviewing, that you invest in Dr. Miller and Dr. Rolnick's book. It's the 2013 third edition of Motivational Interviewing. There you will find all the need-to-know information, as well as quite a lengthy reference list, and several different studies are cited as well. So I would recommend that as a resource. And of course, your instructor, who can always then be in touch with us too for any additional needed help with role playing or anything like that. This has been fun, and I hope that you're walking away from this module with some really good inspiration or motivation to start using motivational interviewing. Thanks.